Good evening, everyone, and a warm welcome to today's webinar hosted by Zebra Medical. I am Atisha Singh, National Sales Manager at Zebra Medical. For those of you who may be joining for the first time, Zebra Medical is a trusted provider of advanced vascular access solutions dedicated to empowering clinicians with tools, training, and support they need to deliver safe, effective, and compassionate patient care. Everything we do is guided by our mantra, care without compromise. This means that quality, safety, and patient outcomes are always at the heart of our work. Today's topic, South African experts sharing midline experience in vascular access, reflects that commitment perfectly. We'll be hearing from leading clinicians who will share their real-world experiences, practical tips, and lessons learned from their midline catheter use in diverse healthcare settings. It now gives me great pleasure to introduce you to our moderator, Dr. Luke Sampson, who is an accomplished doctor and healthcare leader, having a background in both clinical and corporate settings, with a focus in emergency medicine. His expertise span digital health, clinical governance, and innovative care models like hospital at home. Passionate about improving patient outcomes, Dr. Sampson combines medical insight with strategic leadership, always delivering care without compromise. Once again, welcome. Let's dive in and hear directly from our panel of South African experts as they share their unique experiences and perspectives on midline vascular access. Over to you, Dr. Luke.
Perfect. Thank you very much, Atisha, and good evening to everyone who's in attendance. Also, thank you very much to Zebra Medical for inviting me to moderate this webinar on a very interesting topic, and not maybe something that everyone is aware of that can assist in patient care, and that's midlines. So just to move along, firstly, I just want to outline our agenda. We've already completed the welcome introduction, and I myself, Dr. Sampson, am now speaking. We'll then move on to our panelists, who will introduce later on in the slideshow, and then we'll move on to a Q&A session. There will also be a poll, which should be active by the time we get here. If it is not active, I'll let you guys know, but there should be a poll asking some interesting questions about your guys' knowledge and attitudes and practices, specifically related to midlines. So let's move on. So what is a midline? So to do some context setting, we first have to explain that's a little bit more than this plastic device that we see on screen over here. So what a midline is not is a central venous catheter. So those of us from emergency medicine and ICU and even anesthetics will maybe understand central venous catheters more in the context of internal jugular and subclavian insertion, which is highlighted over here. But there are also peripheral alternatives which also enter the central circulation or the central venous circulation in the form of PICC lines. And these can commonly be confused with midlines as well. So if we look at what a midline is, well, firstly, you can see that its tip does not extend past the axilla or into the axillary vein, and therefore does not form part of the central venous circulation in patients, or access to the central venous circulation. And that's the key difference. It is a peripheral device. As you can see, there's similarity over there with the catheter tail and cap, and that is where we can give our fluids, we can give medications, and so on. So what are some common indications for midline insertion? Well, IV therapy for more than 5 days. I mean, we've all had patients that need at least 5 to 7 days of antibiotic, and even longer. I mean, that's covered by the fact that midlines can be used in a setting or patient use case of less than 30 days. Also, patients who have difficult peripheral access. I mean, that's also something that's very common in our setting. This is a very useful use of midlines. And I'll be showing a video shortly on how this is inserted using point-of-care ultrasound guidance. And I think that's where the exciting part on midlines really comes in that it's not just a matter of putting up a peripheral line, it's putting up a peripheral line that improves quite a few things for patients. So midlines are suitable for IV antibiotics, hydration, pain management, and also some non-vesicant medications that might be irritations to patients that also form a very good use case. But it's also commonly used in oncology, palliative care, ICU settings, and, well, also in the hospital at home setting, which is also a topic that is fairly new in these types of discussions, but not new in the medical setting globally. So let's move on to a video by one of our panelists, Dr. Ian Monteith. And over here, he's inserting a midline with point-of-care ultrasound guidance using a butterfly IQ probe. I will just press play and allow you guys to enjoy the video.
We start by cleaning and draping the patient, as well as preparing the equipment and the ultrasound. For this patient, this was done off camera. Then we do the puncture. Here I am using an out-of-plane approach to puncture the brachial vein. You'll see on the ultrasound, as well as feel a pop through your fingers as a micropuncture needle enters the vein. You'll also see a good flashback of blood in the needle hub. Stabilizing the needle hub and flattening the needle to the skin to ensure the needle lumen is aligned with the vein lumen, we introduce the guide wire. At this point, I do the local anesthetic to the region of skin it is exactly needed. I do it this way as I have found the local to be the most painful part for patients. The micropuncture needle is usually not that bad, and I decrease the risk of distorting the anatomy or introducing micro air bubbles, which will distort the view when I introduce the local anesthetic. Once the local anesthetic is in, I dilate the tract, applying downstream traction of the skin and rotating or screwing the dilator through the skin. Then we introduce the catheter over the guide wire. I keep a strict eye on the guide wire during this process using a pinch, pull, release, push technique. I only introduce the catheter through the skin once the end of the guide wire is well controlled. Then I secure the catheter hub using a suture. My preferred suture material is a 3/0 nylon on a Colt needle, using a suture technique I have developed for securing lines. I usually leave the guide wire in for the securing process as it provides more stability for the line, and should the line, as this can be a problem, especially with the shorter lines, slip out, you don't lose your tract. Once stitched and secured nicely, I remove the guide wire, aspirate and flush the line before cinching it and capping it. I then clean the area and the hub before dressing it with a clear dressing with a chlorhexidine patch and attaching the Midline information sticker. Once the procedure is done, I then document the procedure and the line capabilities well within the patient's clinical notes.
Perfect. So now that we have seen a use case and also have a better understanding of some of the indications for a midline, and we've seen the placement of a midline, I'd like to introduce our very knowledgeable panelists to you, the audience. Firstly, we'll have Dr. Hugo Minnaar. who is a critical care technologist based in Pretoria. His practice, critical care and emergency services multiple ICUs in Pretoria and the surrounding areas. And really impressively, his team places more than 500 lines per month. So we'll probably hear some extremely exciting stories, especially about use cases in the pre-hospital space from Hugo. We will also have Dr. Ian Monteith, who you just saw on video now, who is an emergency department doctor based at Millpark and Alberton Hospitals in Joburg. He's also got a very special interest in vascular access, as you've seen, and has inserted over 400 midlines and PICs in his time. We then also have Dr. Neville Flock, specialist emergency physician, also with a special interest in pre-hospital, as well as resuscitation and acute critical care. He has a recent adoption of midline usage, which has broadened his vascular access options in his practice. And then we'll also have Dr. Simon Christie, who's an anaesthetist in private practice in Cape Town, and he has a special focus in inserting the right line for the right patient. He has also been inserting midlines for both his patients and referrals that he has received over the past 2 years. I'll then hand over to Dr. Hugo Minnaar. Hugo, over to you. Thank you.
Thank you so much. I'm just going to share my screen with you. Okay. Okay, so just a disclaimer from my side. Midlines is brand new to the pre-hospital arena, and I'm going to try and answer the question of, is there a case for midlines in the pre-hospital setting? So as you've heard, I'm from this side of the United States of Pretoria, and although we have not had many options or time or can I say suitably qualified people for the use of midlines pre-hospital, I did have the opportunity to attempt a few. So I'm just going to go through what we think the useful pre-hospital midlines is, and obviously we can discuss this afterwards. I'm going to discuss a specific case with you as well, or for you as well. So we would need to ask, is there a case for midlines placement pre-hospitally? So you would see that it's probably useful in patients where there's no visible veins in the arms and the forefeet or in the feet. And I can highlight here that this is new territory. There is absolutely no research on this. The only research is research for the ED department. So there is no research. So this is a great opportunity for someone to open research into this area. So what we thought is, and we've adapted this from the ED guidelines, is that patients with no visible vein in the forearm or feet, no need for IO, or IO is contraindicated, so it's not an active resuscitation case. Patient need definitive IV access for medication or fluids or pain management, as Dr. Luke said. Patients got a long transport time. Patients in a confined space, like the helicopter emergency services or fixed wing transportation, I think it would be helpful in critical care retrieval, or where there's lots of movement for especially where there's no access to central venous catheters. This could very well be a very good option for that. Taking that into account that this is a peripheral line, the tip ends very close to the subclavian vein. So especially if you use the 12 centimeter line, and I've got a lot of experience with the in-hospital placement, and my favorite line is 12 centimeter for French line. But I do think that this would be of great value in the case where there is only someone that has got the placement of peripheral lines on the scope of practice, because this is considered to be a peripheral line, although, as you could see from Dr. Monteith's video that it does use a Seldinger, it still remains a peripheral line. So there could be some issues that we can talk about, and that's sterility, skill, and cost of the midline. So as I said, this is new territory. There was no research. The picture that I'm going to show, permission from the patients have been obtained. So I've been with a patient, 78-year-old patient in pre-hospital setting, a patient with decreased level of consciousness, tachycardia, hypotension, slight fever. I thought that the patient was in a urosepsis. Patient had CA as well and was in a hypercoagulable state. What was weird about this patient, or something that I did see, I've seen it before, is when you press on the vein with the ultrasound, it doesn't open again. So you don't have that collapsibility test that you can do for the veins. So it was quite difficult to assess the veins with the ultrasound. So this patient was in severe pain, 10 out of 10 pain and in need of fluid antibiotics and pain management to be able to transport this patient. There was a long transport time and no IV access. So I was looking for midline access. When I pressed on the peripheral veins, the veins would remain closed, so they didn't open up again. So a few minutes later, I did what we do in Africa, is we make a plan. So I then assess the IJ for placement of a line. You can see that the patient is quite old, no access, and now you don't want to go and drill this patient in front of the family with a IO drill to give the patient fluids and pain medication. And I did the plan was to do an external jugular line, but unfortunately that also closed when I pressed with the ultrasound on the patient's neck. So the only other option then was to go for the IJ. We did place the IJ with one puncture to the IJ, and patient could get fluids, medication, and then for palliative care, I did replace it with a basilic midline after we did some fluid resuscitation. So my ideal placement is first basilic, then brachial, and then cephalic. We can hear from the other panelists what they look at, if there's a choice. We'll do that a bit later. So here I inserted this line and sutured it with, I used 220 silk on a Colt's needle to suture these lines. And then the patient, there was also a very, very long waiting time for ambulance, as the patient unfortunately did not have a medical aid, so we had to wait a very long time. So here is just a photo of where I inserted the line, and you can see that there could be some problems. And my idea here is, if it's in hospital, we do full sterile technique. If it's pre-hospital, I think attempt the sterile technique as best as you can. And what I do is I use a gelco in older patients to enter the vein initially, and then put my wire through the gelco. I don't use a 200K. We can you would hear from the other panelists as well, but I never use it, or I minimally have the need to use a 200K in these patients. It actually makes it a bit more difficult, and the veins it's possible for it to pop. So, and then obviously suture it always so that it doesn't pull out. In the picture that you saw in the beginning, I can go back to it, was let me just quickly go back to it so you can see this picture here is a patient. You can see that this patient actually is an overdose of illicit medication, and she did a lot of her own lines before. And we were actually trying to put up a peripheral line on this patient, and this unfortunately in the ACF it failed, and we then eventually got up a line in the in the basilic area. Just want to go back to the slide. So yeah, suture it in pre-hospitally, and then obviously, and then we can discuss this now, is that you definitely need ultrasound pre-hospital. That is one of the key things with pre-hospital use of a midline. So you need people that is trained in the skill of ultrasound to insert this line. The idea is to get the line in the first time, give the patient maximum satisfaction. I don't think that is what we would do in the pre-hospital line. The idea is pre-hospital is just to get a line up. So to get some sort of line into the patient. And when the patient gets to Dr. Vlok, he can then replace the line that we inserted. So key points is research. We need to do research. So for those that is willing to, I think we need to have people to do midlines pre-hospital to be able to do some research as to, is this a viable option? I think it's a viable option, and how can it be done? And another key point is that we should share amongst each other which situations is this helpful. And as I said on the first slide, my initial thought is that this is very helpful in helicopter emergency service and fixed wing transportations, especially inter-hospital transports where you don't have access to a central venous catheter. Yes, and then we can have any other questions on the chat if we need to. Thank you.
Perfect. Thank you very much, Hugo. And just a reminder, as Hugo said, to those in attendance, you are welcome to ask questions on the chat. These will be addressed in the designated slot at the end. Right now, we hand over to Dr. Neville Vlok. Neville, over to you.
Awesome. Thanks very much for inviting me, Zebra Medical, to come and share my experiences with midlines in the ED. So I must be very honest and very frank. About a year ago, I didn't even know what a midline was. But I quite quickly adopted it to my skill set, and I find it a very handy tool. It's definitely not for every patient in the ED, but it's really, really a magic trick up your sleeve to get you out of a very dark and uncomfortable place. So midlines in the ED, why would we even consider placing a midline in the ED? I mean, why don't we just either do solid peripheral lines or then do a central line? In my experience, initially I thought point of care ultrasound is really a magic thing. There's no patient I can't drip without peripheral ultrasound. But I quite quickly found out is that although I can get the drip up with peripheral ultrasound, the standard Jalcos and the standard intravenous cannulas is a bit too short, and about 50% of them dislodge very quickly after you place them. And that really sucks because now you have to kind of, if you do that effort to place a peripherally guided peripheral IV with ultrasound, you really want it to be one stick and you want it to work. So if you use the standard Jalco, really, in my experience, more than 50%. The literature says about 50%. In my experience, really, past 24 hours, it's not really a reliable line. We know midlines is compared to standard peripheral IVs is definitely more reliable. We've got less rates of extravasation and tissuing. The success rates is much better. The literature reports success rates of 96 to 99%. My own practice as well. Really, it's only one patient I couldn't get a midline up, and I think it's not really a patient factor. I think it was an operator factor. So me being the factor there. We know it lasts much longer. Peripheral IVs don't last long, especially if they get inserted in the pre-hospital setting or if they get done in an emergent fashion in the ED. For really, really sick patients, we know that it causes cellulitis and it's probably not a clean line, and it will definitely complicate in some way. But now you say, Neville, this involves a bit of a Seldinger technique, and this probably takes quite a long time. And I haven't really timed myself, but if you have good technique, and I'm sure you saw Ian's video, he's quite, I think it takes longer to counsel the patient and prep and set up than actually to do the stick and deliver the thing. And in my practice, I think if you're very proficient with ultrasound, if you choose your vein correctly, then really this is not, it's probably a bit easier than putting up a normal peripheral IV. So really, the literature says in the emergency department takes about 10 minutes. We all know if you have a really sick patient and there's about 3 or 4 people trying, I always say it's the crucifix. Everyone, each one on an arm, each one on a limb, and everyone's having a go. 10 minutes is not a long time. We know that when we look from a patient perspective, definitely less attempts or less pokes. And the micropuncture needle has got the benefit of being a very small caliber 21 gauge needle. It's really not painful like a 14 or 16 gauge. We know it's got lower complication rates compared to a central venous line. We don't have any risk of having a pneumothorax. Unless you fall with the needle into the patient, there's definitely, you're staying far clear from the thorax. And the rate of cellular, because it's a bit of a higher caliber line, the risk of extravasation and cellulitis is also much less, because we pay a little bit more attention to sterile technique, because we know these devices are going to dwell a little bit longer. There's definitely clear evidence to show that the complication rate is less. All right. And that's, after all, what we want to avoid. We want to avoid the patient when they come to the hospital looking like this, where they are completely distraught because they know that they are someone who's got difficult veins. And you'll always hear a patient saying, "Oh, I have no veins." And we know that's not possible, but because you must have veins to live. But some patients really have difficult IV access, and it's not just the initial puncture that's the issue. It's actually the longevity of the peripheral access. Getting the line in is half the battle won, and then 24 hours later, now you have to replace that line because it's extravasated, and that really, really becomes bothersome. All right. So if we think about what a diva is, we all think about Beyonce and a clothes. But tonight I want to introduce a new term, and this is also something that I've learned in the past year. That's a difficult intravenous access patient. All right. So a diva is definitely not. So a diva is also Beyonce, but a difficult intravenous access patient is someone that definitely needs a midline. Especially in the emergency department. And a diva can look like a variety of ways. So we've all seen these patients that have just been discharged from the hospital. They've gone to step down, and now they're back to 1 or 2 days later. They've got fever again. They're a little bit more confused, and their arms look like this. Where do you even go? Half of the veins are thrombosed, half of them are blown. You really don't have a lot of options. So when they look like that, they're definitely a diva, and they don't necessarily want to jump in and do central venous access for them, especially if they don't need it. This is also a photo of a recent patient that goes to show you if they was admitted into hospital. It might be a peripheral line here and there, but a week or two down the line, they've had multiple attempts and multiple sticks, and then they really look like a pin cushion. Then we get patients with comorbidities. We get patients with friable skin. They might have skin conditions, eczema, might have cortisone use where they have thin skin, elderly patients with loss of subcutaneous tissue, burns, things like that, which really makes the fixation of a peripheral IV not all that secure, especially if we're talking about sticking it down and only relying on that to making the line secure. So the benefit of securing the line properly also then decreases the risk of it pulling it out, especially if we're doing dressing changes. Then we've always seen these patients, a month or two down the line in hospital, they either have severe edema due to loss of protein and being fluid overloaded, or they have lymphedema in the arm due to previous cancer surgery or something like that. And it's really just almost impossible to get up a peripheral IV of them. So a diva can really look like any one of these patients, or if technically it's anyone that you've attempted more than 2 peripheral IVs and have not won. All right. I want to present a recent case, and this is from my practice. It's a 78-year-old female. She was admitted, she was admitted to ICU for septic shock, and she had 2 central lines up. She had a vascath up. She had an arterial line up. She was then much better, went to step down, and about a week in step down, she was referred back to hospital because now she had hypoxia and delirium. So not really needing inotropes. I'm not really needing any TPN at that stage, but definitely being very, very difficult IV access. GCS 15, and she said the worst part of the hospital stay was actually having all these peripheral IV attempts. What made it very difficult is that she had high-dose cortisone therapy all her life. She had prior chemotherapy, so most of the peripheral veins were absolutely sclerotic. And then she also had cryoglobulinemia, which made most of the peripheral veins, she had cyanotic extremities. So this was really what we had going for her. We had tried multiple attempts getting peripheral IV access up. Even central access was difficult due to the sclerosis of the central veins due to the chemotherapy. And the only thing that we managed to get up was a 22 gauge on the thumb of all places. And this is a patient that needed probably, a little bit more than that. They needed IV antibiotics for at least a week, and in addition to other medications. So what is our IV access plan? So, okay, fine. We tried a peripheral IV, got a very unreliable IV up. It's up, but it's definitely not going to last long. Central access run not really indicated for this patient. Now we messing around, possibly causing a pneumothorax. And yeah, there's some risks with that as well. She's 78. Do we really want to risk poking in the neck and then having a big hematoma there? And then midline was actually the perfect option. So yeah, managed to get a midline up for her, was quite comfortable with it, was a single stick, and she was absolutely very happy. All right. And this brings to my second point. It's not just a happy patient, but it also decreases costs in the long term. If you look at these devices, gelcos are not really expensive, but if you use a 50 on a patient in the course of a hospital stay, then really we're missing the point. And the patients really have a permanent psychological scar after an episode like that. It only takes one admission for them to be needle phobic. And most patients I've met in my practice are needle phobic because they have difficult IV access and they're actually a diva.
Perfect. Thank you, Neville. So just a reminder again to the attendees, we are taking questions from the Zoom chat. Please funnel your questions to the Zoom chat. Other means of asking questions are becoming a little bit cumbersome. Please just ensure that we're moving the questions to the chat. But for now, let's hand over to Ian Monteith. Dr. Ian, over to you.
I'm just sharing quickly. So despite working in an emergency department, I do a lot more midlines in hospital, but I have found that it works a lot better for my in-hospital patients. We see a lot of sick patients who midline's not really suitable for, or a lot of walk-in, walk-outs who aren't going to need it. So I'm going to give you a case study, or two sets of case studies for my in-hospital patients. One of them who has been a patient of mine now for 6 months or so. She's in her 40s and is happily consented to sharing her story. A severe pulmonary hypertension who's on 4 agents awaiting a lung transplant. She's had multiple admissions over the last 5 years with worsening of her pulmonary hypertension, and she's had multiple lines in multiple sites during these admissions. And she's had central lines, both sides of the neck, both sides of the chest, both of her groins for the medication. Not comfortable, quite short term, not able to do much movement or anything because they confined her to bed with her being attached to everything. She had a chemo port at one point for her alloprost, developed sepsis at that, had to have that taken out. She had a PICC line, but developed sepsis of the PICC line and had to have that taken out. So I was asked to have a look at her and chat to her about putting up a midline and using that as access. She wasn't very happy initially when I told her. She's quite needle shy. And when I say quite needle shy, she was absolutely terrified initially for the whole process. And really didn't want to go through something that was going to last 2 to 3 weeks from what she initially understood of it. But I explained the process, went through it, and she finally agreed to it. The first line we put up for her was one of the 12 centimeter 3 French, a fairly small line. It's equivalent to a 20 gauge or a pink gelco. And she, while being terrified going into the process, found the process to be not that bad. It's after her first line, her words to me were, "That's it." that really was not as bad as I was expecting. So we did things a little bit differently with her. I chatted to her, I told her we could look at trying to keep a little bit longer. There have been some case studies of patients who have had midlines in for prolonged periods of time, more than the 2 to 4 weeks that Vigon recommends with their lines. So we chatted to her. I had a nice long conversation, and we decided that we'd keep a close eye on it with routine checkups, routine watching of it, and seeing if we could keep it in a little bit longer. Part of this whole process, and I think this is why we've been so lucky with her and these lines, is I empowered her to look after a line, told her the whole story behind it, the things that she needs to do to make sure that there's no problems with it, the things that she needs to watch the nurses and make sure the nurses are doing, keeping clean hands, changing the dressings frequently, changing the lines, always making sure they clean the hub of the midline, always using gloves, as clean or aseptic technique as humanly possible with it. And we managed to keep that first line for 49 days. She had a second line. The first line was changed because she was starting to get a little bit of irritation and discomfort at the site. There was no features of sepsis, no DVT or anything like that. But it was getting to the point where it was causing her some irritation and frustration. So we moved it to the other arm. So I started on the left arm, we moved to the right arm. The second line we kept in for 47 days, again beyond the generally recommended thing, but again, close surveillance. And she was watching. The nurses were very, very good at looking after the line to ensure that it didn't become septic, it wasn't pulled on, it was well cleaned, well dressed, and looked after very well. We kept that for 47 days, changed that again, just to some irritation around the site. Placed the third line in, and I actually removed that third line today after 51 days, again for irritation. Placed a new, again, 3 French, 12 centimeter single lumen line in for her, and she was an absolute dream today. She understood what was happening, she knew the whole process, and I'm not going to say enjoyed the procedure, but she absolutely loves her midlines and is happy to do the 5-10 minutes of discomfort of having it put in, because it provides her great comfort, good freedom to do her physio and her rehab, while having this line that she's not worried about falling out or about having dislodged or that's going to influence or prevent her moving nicely. So part of it, she's a great patient, and part of it, there's a really good team, and part of it is, Midline is a fantastic device for the arsenal to help us help our patients. My second set of patients that I have had fantastic use with midlines on are cystic fibrosis patients. We at Mill Park are a cystic fibrosis center of excellence. We've got a very well-run unit by Dr. Kathy Baird. And initially, a lot of her cystic fibrosis patients would end up with chemoports because they're usually emaciated, they have poor nutrition as a result of the cystic fibrosis, and don't have the greatest veins as a result of that, combined with the fact that they pick up these funky pulmonary and other respiratory infections that require prolonged periods of antibiotics, some antibiotics that are really uncomfortable to get through peripheral lines, cause burning and discomfort. She was using a lot of chemoports, and problems with the chemoports was she was getting a lot of sepsis, she was getting a lot of DVTs associated with them, and a lot of venous stenosis up and around the neck areas. The midlines came through, we started using them for her patients, and her patients have responded fantastically to them. It's generally a quick puncture, it's comfortable, it's done bedside with the patient, you talk them through the entire process. Small micropuncture needle, again, in a very needle-shy population because they've often had multiple drips at multiple sites. Pop it in, Soldinger technique, small lines if it's needed, the bigger lines if they need contrasted scans or something like that. And they've really, really enjoyed it. We've had a few of her cystic fibrosis patients who, especially with the introduction of hospital at home and the facilities that have been provided by that, who've gone home with these lines to complete their antibiotic and medication courses at home. So they're sitting at home in a much more comfortable spot, and much more comfortable spot, able to have their life function relatively normally without having to sit in hospital for 5 days, 10 days, 15 days, 20 days. And then either they come back for a quick removal, or they pop into their GP or Dr. Bates' office, they cut the stitch, put a little dressing on, and they're happy. So my opinion is it's a very useful tool in our vascular access arsenal. There's a place for standard peripheral gelcos, there's a place for central lines, there's a place for PICC lines, but there is also a place for midlines, and I'm going to be keeping them in my arsenal.
Perfect. Thank you very much, Ian. So we'll be moving on to Dr. Simon Christie, who's an anaesthetist all the way from Cape Town. We are seeing messages coming into the chat. Thank you very much, guys. We'll address those in the Q&A session. I encourage you to keep sending. Simon, over to you.
Thank you so much to Zebra Medical for this really good opportunity, and good to connect with other members of this vascular access group around the country. So thanks so much. So I'm going to talk tonight on mostly about the post-insertion considerations and the care of these patients, because I found out quite quickly, I sort of was introduced to PICC lines and vascular access during my reg time. Matthew Gibbs was a consultant at that stage, and he really sparked my interest in this. And what I found is that it's one thing, and Ian's demonstrated very slickly and very competently about insertion of these lines, but the journey for the patient, that's really the start. And it's a good thing if we can achieve this very successfully, and if we can do it in a way in which the patients are comfortable with, and we avoid some of the pitfalls there. But the patient's therapy begins once the line is in. And these two pictures I've just illustrated here just show, a picture has 1,000 words. A peripheral line, that's the J loop is taped, and I've never really understood this, right across the passage of the line. It's sort of like building a freeway across another road and expecting people to be able to travel clearly. And the one on the right, just about checking things. So even peripheral lines can last a long time, but if we don't open up and unmask some of these dressings, we find ourselves missing some of the problems. Here's just a little bit of scanning technique. So actually what you might see on the ultrasound for those who haven't been exposed to it. So a video is basilic veins and the other veins in the classic Mickey Mouse picture. So it's important to scan not just around the arm looking for options, but also up and down the length of the arm. And on the right, just to show you a nice classic picture of something that's been secured and the dressing applied and all these instructions given to the patient. And again, a scanning video.
Okay, we're just doing some scanning.
We'll be a bit talking over the top of it.
Mickey Mouse, if we include them, we'll press down, we see the artery in the middle and the group of veins, there we go, winking at us. There's the neural sheath.
And moving more lateral, a more superficial vein away from the neural sheath.
As we go up, we can see it getting bigger and bigger.
So again, sometimes what you see initially may not be what you're looking for, and it's important to scan both up and down from insertion. And then on the right, just illustrating again, a little tip that I use when suturing is that I actually tie the suture around the introducer, and that by that way I don't knot the suture line to the skin to cause irritation. And again, the video is just illustrating the background, both to have a look in plane and out of plane and longitudinally and in transverse section. So again, scanning techniques here. I'm hoping this video on the right will play in terms of assessing the patient at a previous drip placed in an IV there. And you can see in the picture before the video plays that there's a clot there. So, what you may see at one point changes down the length of the vein. So scanning is important. Unfortunately, that video didn't play. I'll try and play it at the end. So really the objective is this maximum prevention of complications and the reduction of punctures. So if you typically look at some of the patients, if they need 30 days of IV therapy, And we're looking at a standard peripheral, may only be in 1 day, but sometimes 3 to 5 days. Even if it's in 3 days, if they need a course of long-term IV therapy, that's at least 10 insertions. And if it's 5 days, and each of those lines that you manage to get last 5 days, and that's 6 different insertions. So very quickly things add up and they multiply. A very useful device, and considering what you may do through a midline, so once you've made the choice, as others have illustrated, between, say, your peripheral standard IV access, your midline or your PICC line, or something like a port, is just to realize that in that landscape, the midline sits in terms of the medications you may use, the pH of those should be between 5 and 9. It shouldn't be, the slide didn't come up properly, vesicant, irritant, phlebotic, or anything else. And you should ensure that the osmolarity is between less than 600 to 650, which in a sense also excludes things like TPN. Midline does not end centrally, so one needs to just bear these bear all of this in mind when selecting what I like to say is the right device for the right patient. But extremely useful is this BD Infusate Companion, which can be downloaded iOS or Android. And it really it's a combination of all of the medications that are available. You can select them. They will give you all of the characteristics. And so when you are referred a patient who needs a certain therapy, you can use this app very, very usefully without keeping it in your mind to decide what you might need. So this is me in practice, inserting a line, full sterile technique in hospital. Most of my lines are placed in hospital, but it's important in terms of, once we've managed that and patted yourself on the back and everyone's happy the line is in place, is this ongoing management. And it's very well to think that we can do one of this parts, the first part, successfully. But if the chain of this therapy breaks at any point after that, we need to know how to manage any potential problems that might occur. And typically, and most commonly, obstruction. The other is this MARSI, which is essentially complications relating to the skin care, and the partial or total removal of the catheter, thrombosis within the vein, and the selection of the size to the vein ratio, and then infection. And typically what I hear most of the time is once the line is in and it's working, I often get complaints back or feedback from either the sisters in the ward, or if patients go home and are treated peripherally, that the line isn't flowing well, they can't draw blood back. And these are all the components of a midline. It's very rare that you can aspirate blood back from a midline. As it warms inside the body, it often collapses. So to get blood back doesn't necessarily mean it's extravasated or moved to a distal point, or that the line is blocked. And just to bear in mind, to explain to people continually that these are thin lines, very small gauge, 3 or 4 French typically, and 8 to 12 centimeters. So things, if just fluids if given to patients or treatments given to patients and hung simply to gravity, is a very slow process. And one should always consider this in the medication. And I'll follow that up with 2 of the case studies that really hit home this message for me. So the first was a 63-year-old female. She was scheduled to have 35 days of BD, so twice daily, once in the morning, IV antibiotics. And I did a 4 French 12 centimeter midline for her. Again, bearing in mind the duration, if the line would be continually assessed and replaced if needed. But she was to be discharged out of hospital and sent home. And for the first 2 or 3 days, I didn't hear anything back from the team that was scheduled to look after her. And then over time, someone said, well, things are taking a long time. So I inquired more and tried to follow up what's going on. And I was quite amazed and astounded to hear the first day, the infusion time was 5 hours. She needed 2 antibiotics, linezolid in a diluted solution of 300 mils and ceftriaxone at 100 mils. So essentially, she was being given 400 mils of fluid in the morning and 400 mils of fluid in the evening. And if you look conceptually at what we're trying to achieve with these midlines or chronic vascular, long-term vascular access device, we're trying to get a patient out of the hospital, at home, try and free them up to do the things they usually do. And in this case, we got her out of the hospital, but paradoxically committed her to 800 mils of IV fluids for 35 consecutive days. So we've got her out, destroyed her glycocalyx, and committed her to lying in her bed for 10 hours a day. I just don't think that we're really achieving what we set out to here. So what did we do? Well, the sisters were reluctant a little bit to change some of the dilutions, but I essentially moved the linzolid 300 mils, set it on an infusion drive, and set the first at 450 mils an hour, and gave that over 45 minutes or 40 minutes. And then I moved the Rossifin to 20 mils as a dilutant, and I gave that over 20 minutes. And that certainly, although the total volume of fluid didn't come down that much, the patient was only having the infusions, both of them, over a time of an hour. The second, this
Sorry,
picture,
Simon, just heads up, 1 minute.
almost done. The second just illustrates this patient here. Again, drip managed at home. This is a midline, mid forearm on the left. Quite a difficult insertion. He's got a little bit more increased adiposity. And over time, they gave the infusion to him just hung to gravity, again, not driven in. And sometimes if the infusion is large, you're getting back seepage through that and seepage of that fluid into the vein. So just things to always be managing on a continual basis if you're going to start this patient on the journey. In summary, and we can talk more about this at the vascular access care course, you've got the patient, you've got the indication, you've got the procedure and the therapy. And I think it's important to have the overall picture of where this patient's going and then decide if the therapy in total has been successful. Just as an end, this is myself and Jean and my esteemed spinal surgeon, Dr. Machampa, and Jean very kindly gave me a set of vascular sleeves that I use all the time with all my patients. It really helps a lot, and I'm very appreciative for all the help from Zebra. Thank you so much.
Perfect. Thank you very much, Simon, and thank you to all of our panelists. So we've received quite a few questions, which we'll limit because of time factor reasons. But I think very interesting topics that have been discussed about very interesting use cases and settings. So just about the poll that we mentioned earlier. Unfortunately, it's not functional at the moment. We will be sending that offline after the webinar. But let's dive into the questions, and to the panel, this is open to anyone to answer. I think let's start with some of the basic understandings around midlines. The first question that I'm going to ask is, what are the common anatomical landmarks used to place midlines? I know that we spoke a lot about point of care ultrasound usage in this case, but not everyone has access to these. So what are the anatomical landmarks that you guys use?
I'll share one perspective. Anyone's welcome to jump in. So classically, I only place midlines in the upper arm. And then you divide the upper arm into thirds. So the proximal third and the distal third is not where you want to be. Proximal third, then you run the risk of the device actually going into the axillary vein or the subclavian vein and causing thrombosis. And then if you're in the distal third of the upper arm, then you run the risk of causing extravasation. So the middle third is where you want to be with your insertion point in the middle of the middle third. So the average upper arm is 21 centimeters. So it's about 777 centimeters. Kind of the green zone. There's a nice, if you just Google midline insertion sites, you'll come up with nice pictures explaining what I'm telling you in words. But that's classically where I use midlines. Obviously, it showed where you can basically put a midline in any vein. This is completely off label, but I'm sure you can place it in any vein. But if you use it for the indication as for long term IV access or medium to long term IV access, then the upper arm is where you want to be, the middle of the mid upper arm.
Perfect, Neville. Thank you very much. Anyone wanting to add to what Neville has said?
I just want to reiterate. I don't know who asked the question, if it was pre-hospital or in hospital, but one should not attempt midlines, I think, without an ultrasound. You definitely have to use an ultrasound. So there's no anatomical way of determining where the vein is, except with an ultrasound. So you sort of defeats the purpose of a midline or any line if you want to do it without ultrasound, because you're gonna go in and out like someone with it, like Simon showed that picture of that hand. That was typically someone that was just poked and hope you get the line in. So I wouldn't advise anybody to go on an anatomical place for any vascular access. Use a ultrasound.
Perfect. Thanks.
Just quickly, I mean, I absolutely
Yeah.
agree with both of you, because especially that mid-arm area, as described, is a very close nerve cluster there, and some of those veins, especially basilic side. So if you go more lateral, those veins are in very close proximity and actually quite irritating, even under ultrasound guidance for the patients to have them inserted, and the artery is also sitting there, and it's very difficult. And I think without ultrasound, I wouldn't recommend it, and you're really not sure that you are where you should be.
Perfect. Perfect. Thank you very much, guys. Then I think your answers take us through to two other questions that we can sort of deal with at this point. First one is complication rates of DVT. How frequent is this? And then the second one is what are common mistakes that are made during midline insertion? I think we spoke about one of these in that, if you're not using ultrasound, you're not doing it right. So what else can we understand in terms of DVT risk and occlusion, and also in terms of insertion mistakes?
So unfortunately, and Ian places a lot of in-hospital lines, and as the ultrasound that Simon showed, you do develop clots in the peripheral vasculature as well, unfortunately. So depending on the disease process of the patient as well, you unfortunately would get some thrombosed vessels after multiple use of the midline. I've actually haven't had severe complications in midlines. I have had big complicated thrombosis in peak lines, but in midlines I haven't. I'm not sure what the reason for that is. I think the flow rate might be higher because you've got only one lumen. We use only one lumen, and I suppose that could be the reason we haven't seen thrombosis in that. Other complications, infection rates quite low. As I said previously, I spoke about pre-hospital, but my experience really is in hospital. The pre-hospital is an area where we need to open research. So in hospital, I haven't seen a lot of infection because it's being done with full sterile procedure. So the same way you put in a CVP or a Vascath or any of those lines you use for a midline. And for that reason, I think it remains a very good option. That's why I think Ian can use those lines for much longer because you use full sterile technique.
Perfect. So that then goes to another question, another theme of question about where can we place lines in patients, and can they be placed anywhere? And there's one question that came through. Let me just get to it quickly, 1 second. Currently treating a patient with SVC syndrome due to thrombosed chemo port, occluded IJ, and most of SVC as well. Can I use midline in lower limbs?
Yes, but it's not as nice as using it in the upper limbs. I've used midlines in both the forearms and on the legs. I haven't done any in the thighs. As more because they're longer than a standard Jelco catheter, just so it's got a better staying power, but they didn't last that long. There was usually a phlebitis or they would clot relatively quick. I never got them for the same duration. But in a patient who is difficult to access, who you don't want to be poking into the arms, you can use it as a very off-label, but as a longer Jelco, basically. That's a bit easier to secure and works. You can stick it into any vein. It's just not as effective as it would be in your brachial, your basilic, or your cephalic veins in the arm.
Sure. Perfect. Thanks, Ian. And then I'm just going to split time a little bit and ask one more question. Neville, sorry, did you want to add something?
Yeah, no, I just wanted to go about you probably any intravascular device has got the risk of forming a clot. Doesn't matter where you put it, but I think the benefit of having a bit of a longer catheter is that your risk of extravasation is much less. So if you are worried, if that's a particular concern in your patient, and where especially if you're using high osmolality agents, not exceeding the 600 microosmoles, but if you are using a bit of a higher thing, then the risk of extravasation is much less than with a normal peripheral IV.
Perfect. Thanks, Neville. Then just one more question around the use of midlines for transparental nutrition. What have you guys found in your use cases and patient settings regarding that?
So I've had quite a few of our oncology patients who have, but it's the peripheral formulation of TPN. It's not the central formulation of TPN because it's not a central catheter and it's not terminating far enough into the central blood supply to dilute down without causing issues. So as long as it's a peripheral formulation and it works quite well, they don't have to worry about having a drip change every 6 hours, 12 hours, a day or two if they're lucky, because it's dislodged or it hasn't been looked after or it's been pulled on. So it's nice for the peripheral formulation of TPN.
Perfect. Simon, did you have something you wanted to add?
Yeah, I mean, I absolutely agree with that. You definitely, I know people are asking about it, and you definitely cannot give TPN through a midline catheter. It shouldn't be considered unless, as Ian said, exactly as Ian said, it's just that's a contraindication. And if that's what you're needing, if you're choosing between not having a CVP or a central line for TPN, then you should be placing a PIC and not a midline. Absolutely.
Perfect. Thank you both, gents. And then one last question, because I think we've been very adult medicine dense in our conversation topics. There's a question of the use of midlines in neonates. Have you guys had any experience or exposure to that?
Not neonates, but I have done it in some small children. It's doable. You and the Zebra or the Vigon lines, they provide a 2 French, a 3 French, and a 4 French. So a 22 gauge, 20 gauge, and an 18 gauge. You'd use generally the 2 French line. It's just a lot trickier. It's doable, it's fun, but it is much smaller things, much smaller movements. Yeah, like everything with kids.
I think you know I think you're speaking to a group of key opinion leaders on midline insertion, and someone will first in sitting in line on the kid is fun. But just I'll take the last short question before we close off, guys, and that one is, are midlines reimbursable by medical aids? And I mean, the short answer is yes. So long as you're following correct practice guidelines and gold standards as we've discussed, and you're adhering to patient safety, of course you can bill for it. If it gives a good patient outcome, and that is what we're wanting to achieve by putting patient first and not line first, then that's the best way forward. But I think thank you very much to everyone, especially our panelists, for joining. I think we had some very interesting presentations, very interesting topics and discussions. Thank you to those who shared questions. Sorry that we couldn't get to everyone's questions. We are constrained by time. But we will be sharing a poll and a few other resources offline with those who have attended. Thank you once again for joining, and we'll see you next time. Keep well.